So, how are you?
Good, very good.
Great. So, finally, we're able to start the program.
Yeah,
Thanks to you.
not a big deal, man. Anything for you. You're the man.
Yeah. No, I'm not the man. You're the man. You're helping us. That's always. I think,
Yeah, what?
what's the time now there?
Morning 9 o'clock.
So, it's 9 already.
Hmm? Oh, 8:30. 8:30 in the morning.
Yeah, 8:30. I think she'll start by 9 only, right?
No, we said to join a little early, right? We need to just make sure her slides work and all that.
Yeah.
I want a lot of questions. Everyone should be asking a lot of
Yeah,
questions. Okay,
sure. Yeah.
that's
Yeah.
the goal. Also, um, I texted her, just waiting for her.
Yeah. So, how are things there?
Very good, man. Can't
Good.
complain.
Good.
Pretty easy. Kalen, I spoke with Kalen the other day. Seems
Yeah.
like, yeah, while we are waiting, the September meeting, we need to put something together, man. There are a lot of
Yes.
speakers coming.
Yeah.
We need to just, I spoke with Raman. You're part of the organizing team.
Yeah.
So we need to just put things together.
So who are all confirmed as of now from US
Uh,
or abroad?
Nikhila, Julina,
Yeah.
Matt Brigger,
Yes.
um, I'm losing names now. I sent him the names. There are a couple of GI people, one
Mm.
pulmonology,
Good.
uh, then who? Brandon,
Mm.
uh, Tahir Valeka from Chicago,
Good. Yeah.
and hmm, I'm blanking out on names. There are more names, at least
Okay.
two, three more names.
Yeah. So what about that little confusion about the serologist meeting at Tennessee that's also happening at the just
That's the weekend before.
weekend
That's
before?
how we plan. The
Okay. So
aerodigestive meeting is the week before.
before,
So
so they'll finish it and then come here, is it?
yeah, oh, means not everyone is coming, right? So
Yeah.
whoever
Many
is
many of them.
coming, yeah, quite a few
Yeah.
will be coming.
Yeah.
Um,
Yeah,
very-
generally we also have one meeting every year in Chennai.
Mhm,
Last time you attended, and
mhm,
this I mean 24 we joined with Larynx 24 conference.
mhm,
So yeah, Sohit came for that, and something like that. The next year, 2025. I don't know
mhm.
whether because this is going to be a big conference, this is happening, whether we'll be able to organize one in Chennai or not. Not sure about it. Mm,
Maybe
because
next year, man. Next year,
yeah,
do it there. I'll
yeah,
come as well.
yeah, sure, yeah, right. So yeah,
Kalen is
we'll think about.
coming. Kalen
Sorry.
might be coming to Bangalore because he called me asking, like,
Yeah,
should I go? I said if Thiru is organizing, go for the Thiru's course. It's okay.
Yeah. Yeah.
But if you're not, then he'll come to Bangalore. Then
Yeah.
Karthik is coming,
Right. Okay.
and Mike Rutter will join in online, and
Okay.
Catherine Hart will be coming, and
Okay.
then Dave Molter,
Yeah.
uh, Shian,
Yeah.
Kishore.
Yeah.
So yeah, good number of speakers we
Yeah.
have.
Yeah. It's going to be a yeah. It's going to be a
Probably
great meeting.
10,
Yeah. It's almost like
10,
every
12.
person is going to come.
Yeah, like, and maybe more will come. I need to talk with Matt and see because he
Mm.
did talk to the Aero team and was seeing who else will come.
Okay.
So maybe Jeremy Prager
Mm.
or we'll see. But it'll be a good meeting. There'll be
Yeah.
quite a
Yeah. I
good
know. Yeah.
number,
Yeah. Yeah.
and we'll do it this time. What we'll do is we'll do at least half a day or maybe even one full day dedicated Aero stuff.
Okay.
Because the way I look at it is, a lot of you guys are doing good airway work.
Yeah.
Now, the next step is how do you improve your outcomes? How do you increase the other patients you're seeing? Part of it is swallow. A lot of patients we see in the aero is all swallow patients.
Yes. Yes. Yeah.
So improve increasing the swallow stuff. I don't know.
Yes.
Maybe we can ask any of the speech pathologists. The problem with them is the hospital doesn't pay for them.
Oh, okay. Mm.
It is little challenging for them to travel all the way.
Right. Right. Mm.
Okay. Lauren will be joining. They're joining.
Yeah.
Bishwa is there.
Biswa?
Yeah, Bishwa Gogoi.
Yeah.
He's keeping
Yes,
quiet in the
sir.
back.
How are you? I'm listening out.
Hey. Yeah.
Yes,
Biswajit,
sir.
welcome.
Oh, yes. Thank you so much for organizing. Deepak, sir, how are you?
Good man.
Yeah.
I'm
After a long time.
I'm making breakfast for the family.
Today is Sunday, no, sir.
Sunday, yeah,
So
Sunday breakfast. No,
I know.
he does,
Yes.
Biswajit, he cooks not just for his family. So his family is like extended families. Many people will be going for Sunday breakfast, dinner. Or, he organized that kind of meetings as well. You know,
I
people
I made
people go there with
sabudana
sabudana,
khichdi, sabudana today.
sabudana khichdi. He introduces Indian food to all the Americans.
Mm, mm.
You know, yeah,
Oh,
he
they
loves.
once they you remember Thiru when we went. After that, they crave for Indian food so much.
Yeah,
One of my nurses was pregnant. She was like,
okay,
"I'm craving Indian food like crazy." So
okay.
she found Indian restaurant next to her, and she went couple of times to eat there.
Oh wow, great.
But I make vada pav for them and take
What
them on a
about?
regular basis.
Okay,
That's easy to eat Indian burger.
yeah. I mean, easy
Or
to
We have
eat.
always,
You know,
yeah,
you know.
easy to take as well.
Yeah,
Easy
take us up. Okay.
to
So he's a big energy. Big energy, huge energy man. He manages many things, not just not just airway stuff. I mean, the good thing about him is like, he likes to be with among people and he tries to help people. Like, he's, putting it together, this meeting for us. I just requested him because the pediatric airway stuff is not going well at the moment in the country. So I asked him, can you do that? And immediately he said yes, and all the people like swallow pathologist, everyone around him is like that for him. If he says, immediately they say yes. That's it. So that way, he command things in US.
No command. It's
I
all
mean,
team.
command means like no, you got a good, that
Yeah.
organizational
No,
capacity.
people. Yeah, people respect when when you're good, they'll respect you.
Yeah, yeah,
Your intentions are good, right? So,
right, right, exactly.
so how many people might come?
I mean, we have slot for 100 people.
Yeah.
So whichever is
Oh, it doesn't
coming,
matter. The way I
yeah,
look at it is even one person learns something from it and makes a change in their practice.
yeah, definitely, definitely. But there
It's
are many
worth it.
people interested. I hope there will be more
Yeah.
joining.
I sent it in there is like a couple of other groups as well. So
Mm,
I forwarded it there. There is like one Karnataka group
yeah,
um, and stuff. So we'll see if anyone is interested in joining.
yeah,
But people
yeah.
who are
There'll
there,
be there'll be a good crowd. I'm expecting a good crowd.
Yeah.
yeah.
I'm sharing it to our pediatric colleague also.
Mm,
Hmm. Yeah,
So,
means it applies actually. I didn't think about pediatric colleagues, but they are the ones who first see and they need to
yes,
identify and then forward it to
yeah,
you guys, whether it is the speech therapist or because I think a lot of it is not picked up, and that happens
yeah,
here as well
yes.
because
Uh-huh.
people don't realize what to do in those situations. They think, oh, kid is coughing and choking. It's not. It's okay. They'll get over it.
Mm,
But the problem is, by the time they wait and they come, it's they have learned bad habits and they're not eating
mm,
properly.
right. So how is life there in US, Dr. Deepak, after Trump era?
Trump every day is. You don't need to watch any movies. You don't
Any movie?
need to watch anything.
Very
There is
exciting.
something every
Even
day.
for Indians, it's exciting now.
Yeah, yeah. In India, what 24/7 news? Everyone is always watching news. So
Yeah,
news
yeah,
channel they have to fill up something. So they keep
yeah.
doing that.
Right.
At
Yeah.
least in US, there is not that much craziness about
Mm,
TV news. They are crazy
mm,
online. Whatever they get, they'll watch for a few minutes.
mm.
Um, but it's crazy, man. Crazy. I don't know what will happen to the world.
Yeah. I mean, because the whole thing is involving the global politics and the recent meeting with Zelensky and all is like the news all over the world.
Yeah, yeah.
Yeah,
Not
now
just
it's
that,
it's
it
happening in the
just
White House.
changes the whole dynamics of world power,
Yeah,
basically.
yeah, yeah.
It'll be interesting because I think Europe will come together. Out America will lose its power slowly if they continue to do this.
But in that case, as people predict, it's going to be a World War III because these people, US and Russia join hands together, and Europe is against it. Then it will be the proper war kind of situation will be
No,
there,
no,
right?
I don't think US will join Russia.
Mm,
They might not support Ukraine.
mm.
If they join Russia, the people here are too anti-Russian, so
Ah,
there's no way they'll support it.
okay.
So it's already some backlash is happening.
Mm, mm, mm.
So we'll see. Um, we'll see what will happen. Uh, no one joined yet from the team. The main reason was to just make sure the slides are working okay.
அது மியூட்ல இருக்குது. இங்க வால்யூம் குறைச்சிடுங்க அதான்.
ஃபோன் இருந்தா வரும்ல.
தெரியாதுன்னா அதான் வால்யூம் குறைச்சாச்சு.
சரி, இதை எடுத்து விட்டுரு, ஒன்று எடுத்து போடு. இதை எடுத்து விட்டுறேன். என்ன அண்ணா, இது அப்படியே இருக்கட்டும், அவ்வளவுதான். இதுல போயிடலாம் வேணாம். சும்மா கதை வச்சு
நானும் இப்போ பொறுமையா உட்காந்து யாரா பண்ணது கதை அடிக்கிறாங்க.
You want to show off that you know this fellow. Thiru.
என்ன டைம் லாகின் அது 2 நிமிஷம் இந்தியன் பீரியட் ஹலோ அவையோ ஆரம்பிச்சிருவாங்க 3 மினிட்ஸ்ல. இது என்னன்னா அரை மணி நேரம் பார்த்து விட்டு
10 பேர் தான் நீ ஏறி 10 பேர் தான் ஜாயின் பண்ணிருக்காங்க.
உட்காந்து கதை அடிச்சுட்டு
9 o'clock we'll reach home, Shanti. Then Pops will come. Then ask, இப்போ என்ன அவனுக்கு டாகூர் எங்கேயாவது சேர்த்து விட்டு போலாமான்னு பாக்குறேன் நான். அப்புறம் அவனால சேர முடியாது. எல்லாம் பார்த்தா 1 hour 10 minutes 1 hour 10 minutes தான். பாலாஜி தான் கிட்ட இருக்கிறதுலயே 40 minutesல போய் சேருது. மற்ற எல்லாம் 1 hour 10 minutes தான் ஆன் ஆவரேஜ். லலிதாம்பிகா அதெல்லாம். லலிதாம்பிகா வந்து உன் கிளாஸ்மேட் தான் டீனு பாலசுப்ரமணியம். ஏன்னா இதுல டாகூர்ல என்னோட இவரு முத்துக்குமார் இருந்தா டீனு. ரமேஷ் வந்து பெத்தால் இவரு எஸ்எஃப்எம் சீஃப். இஸ் அ நான் டாக்ஸிக் பர்சன் ரமேஷ். அதனால அவர் தெரிஞ்சு எடுத்துப்பாரு. வாணி எங்கேயோ இருக்குது. இது ஒரு இதோட கிளாஸ்மேட் ரோஸ்லின் ப்ரொஃபசர் ஆயிடுச்சு. முத்துக்குமார் இல்ல. அங்க போயெல்லாம் சேர முடியாதுடா, எனக்கு கிளாஸ்மேட் சொல்லிட்டேன் அசிங்கம்டான்னு சொல்லிட்டேன். சரி, ஏதோ ஒண்ணு பண்ணி சேர்த்து விடலாம் இன்னொரு 1 or 2 monthsல. இந்த ஆளு இவ்வளோ மெமோ கொடுத்த அப்புறம் ஏன் வச்சுக்கிறானுங்க? இவன் இன்னும் நம்பிக்கை இருக்கு. they will not send me out. ஓகே, நம்பிக்கையா இருக்கான். இந்த கலைவாணி தெரியாம ராமச்சந்திரா தான் வேணும்ட்டு உட்காந்துருக்கு. புரிய மாட்டேன் இந்த விஷயத்த. இன்னும் என்னதான் புரிய வைக்கிறதோ. நான் இருக்கிறப்பயே சேர்த்து விட்டா ஓகே. அஸ்வின் பசா சேர்ந்தா 1.4 lakhs கொடுப்பான். 40,000 50,000 நாடிவன். மணி பத்தி எனக்கு ஒன்று ஐம் நாட் இன்ட்ரெஸ்டட். ஸ்டில் அதுக்கு பிலீவ் தட் தே வில் கீப் ஹிம். அவர் சொன்னாரா மகேஷ் சொல்லிதான் அனுப்புறா. சும்மா சொல்றாரா இல்ல சொல்றாரா? அந்த ஆளு ஒரு மாதிரி ஆள் தான்.
We are listening
but
to all
that's
your
okay.
private conversation, whoever is on iPhone.
ஈகோ எல்லாம் முடிஞ்சு போச்சு. மீட்டிங் கூட பேசிட்டு வருவேன், அவ்வளவுதான். ஐம் நாட் வெரி இன்ட்ரெஸ்டட். பட் நவ் வந்துட்டு முடிச்சு. அவன் சுச்சுவேஷனும் இதாதான் இருக்கும். நான் இதுமாதிரி திட்டதில்லை எதுவும். ஓகே, இதை பண்ணிட்டு
here. So when you talk, you'll just. Okay. Hi, good morning, or good evening, right? It's evening. Yeah.
Hi, Kathy and Lauren.
Hi.
Hello. How are you?
I'm good. How are you?
We are doing well. We're
Good
excited.
morning. It's good
Yes.
evening for us. Good morning for you.
What time is it there?
It's going to be 8:30 p.m.
Okay. Yeah. It's late.
Yeah. Yeah.
Can you, Kathy or Lauren, can you put up your slides to make sure it's working okay?
Yeah, I'm
Absolutely.
doing that right now. So I had to
Yeah.
unconnect the mouse, but now I don't have a mouse.
Okay.
Or thoda.
Because that has to go.
Butter done.
Let's see if we, because I can't.
Okay.
Plug.
Is another.
There should be something on the computer, actually.
Oh, you know what? Let's down. Okay, put that in. Check that out. When you hit that, it won't come out.
Look. See another, do you see anything on the back of there? Look on that side. No, because I have to have that. I need 2 slots. That's the problem. There's only one.
All right. So you need another.
This slide.
This would
Sorry,
be-
we have our slides. It's just our mouse situation.
Mhm.
Sure, maybe back here. I could. Maybe I put it in here, or the mouse could go here.
Let's put the mouse in.
I just want to see if it's back here. It might not. Yeah, try the mouse back there.
Okay.
It's a little too big, I think.
This one should have more than one opening.
I know, that's kind of the interesting part is that it doesn't.
We could go to your computer. Probably.
If you email me the PowerPoint that I sent to you.
Yep.
I can pull it up through my email. I forgot
Okay.
to. Just forward it to me. That's really interesting. Yeah, it's all right there. I just can't because the mouse has to be plugged in. Just go.
I'm not gonna go my phone in.
Okay, and just forward it to
Okay.
LX. That one I'll tell you.
Working out little technical things. Look at this.
Okay.
Hey, Nikila, good morning. Thanks for joining in.
Good morning, everybody. Excited to kick this off. Dr. Thiru, nice to see you.
Hi, Nicola.
How are you?
I'm good. How are you?
Good, good.
How are the kids?
Everybody's good.
Good.
Yeah.
Excellent.
Your children are doing well?
Yeah, they're good. They're good.
Good, good, good.
And at Texas Children's. So. Thanks for a second. Okay. So there's this one, and then there should be. So like I have that there,
You
and
might,
then
you see, you might have to
yeah,
pull
and
one
then
of these
try.
out.
Oh, but how do you know which one? Oh, I didn't see
or
that
there's
one.
another one, yeah.
You're the best. Thank you. You the bomb. Thank you. Okay, I didn't see that one. Now I got it. Okay.
Is it working?
No.
Okay.
Okay,
Yeah, you're able to
Okay.
see your screen.
sorry, we just had to find, we got it now.
We got it. Mouse.
Okay. Good evening, everyone. Good morning here. So let's kickstart. Um, First of all, thank you, Thiru and his team, for putting this together. We have amazing speakers. Catherine Turk is our senior most SLP who is integral part of the Aero team and pretty much trained most of the SLPs along with Christina Rapazzo. Both of them formed a formidable team and trained a lot of the SLPs in town and even further. So um, Kathy has been like a lot of the SLPs for us when the new SLPs join in, they need to have a structured training and forming a structure on their training and making sure everyone is doing the right thing. So Kathy and Christina has been very important part of that. Lauren and Natalie are the newbies, not newbies anymore. It's been few years now, but they've joined the Aero team and they're doing amazing work with us and taking care of a lot of these kids with swallowing problems. And thanks to Nikila, who joined us from Emory and is a world expert on swallowing. So I'm glad Nikila is joining this as well. What I would like during all of these sessions is to make it very interactive because there might be certain things which we are doing in a certain way, but with Indian context, you might have to change a little bit or do things and make it, you can teach us as well. So it's not a one-way thing, make it two-way, but also make sure that if you have questions, don't feel shy to ask questions as we go along. So let's get started. Thank you all.
Okay, well, good evening. It's morning over here. When he mentioned that I'm doing a lot of training, it's because I've been here a long time. So basically, I've worked at Texas Children's for 30 years. And throughout my tenure here, have really grown to love our field, especially in feeding, pediatric feeding and swallowing. So today is one of 6 lectures. And this is just a infant feeding and swallowing assessment and treatment. But we will have different lectures on once a month on the first Sunday of each month. So I'll start. Infant feeding and swallowing assessment and treatment. Again, this is Lauren and I'm Kathy. The agenda today is to go over the neurophysiology of swallowing, normal swallow in infants, what is normal, feeding and swallowing milestones, and how do we assess feeding and swallowing. There are 3 major ways that we look at feeding and swallowing. The first and very important part is the clinical assessment. It's our bedside swallow. It is where I get to know, or we get to know the patient. We know their history. We know what they're doing at the specific time. And we get an idea if we need to do other kind of adaptations or modifications with their feeding, or maybe they have swallowing components that we need to further assess by using a video fluoroscopic swallow study. You may see MBS or a fiber optic endoscopic evaluation of swallowing or fees. Okay, so this is part, maybe a review for many. and may be new to some, but we hope throughout this whole series that you feel like you get something that makes you excited to be a speech language pathologist. First of all, the neurophysiology of swallowing is very important to understand. It's a complex sensory motor activity, coordinated contraction of more than 20 pairs of muscles in the oropharynx, the larynx, and the esophagus. It involves multiple levels of nervous system, including the brainstem and cortical controls. Yeah, that's better. Yeah. Okay, the most important part is like the central pattern generator. The CPG is located in the medulla oblongata. Its network can be modulated by peripheral and central inputs so that the swallowing pattern is adapted to bolus size. So when we swallow, depending on what consistency, what texture, what bolus size, we have a pattern that is adapted for us to have a safe swallow. When we also talk about neurophysiology of swallowing, we know that it involves several brainstem motor nuclei and two main groups of interneurons, the dorsal and the ventral. Neurons in the dorsal group are involved in the generation of the swallowing pattern. The neurons in the ventral group are involved in distributing the commands to various neuronal pools. They're key cranial nerves for swallowing, and we'll go over there's really the ones that we're going to go over are the most important are 9, 10, and 12. But first, the trigeminal cranial nerve. It is important for jaw muscles and facial sensation. Difficulty with mastication, difficulty with sensation would be attributed to damage to this cranial nerve. Cranial nerve number 7, we know it's a facial cranial nerve. It's important for our facial muscles, and we notice that when we have some asymmetry of the facial muscles, that it could be contributed to a cranial nerve damage to 7, and it also could be contributed to a genetic condition. Okay, then 9 is the glossopharyngeal, vagus, spinal accessory, and hypoglossal. Let's just kind of review these really quickly. The vagus, the sensory parts provide sensory information from the velum, the pharynx, and the larynx. It's an internal branch of the SLN. What does the vagus nerve do? It innervates the glossopalatine and levator villi palatini muscles, which raises the velum. It innervates the pharyngeal constrictors, which is the most important cranial nerve in our swallow, the pharyngeal swallow. It innervates the pharyngeal constrictors, intrinsic muscles of the larynx, and responsible for vocal fold adduction during the swallow. Very important, critical. When you have damage to this cranial nerve, depending on what condition the child has undergone, it can be very crucial in our swallowing and our voicing. Glossopharyngeal, the motor innervates the xylopharyngeus muscle, which elevates the larynx and pulls it forward. The sensory component provides sensation from posterior 1/3 of the tongue, the velum, and the upper pharynx. And the hypoglossal nerve. We know it innervates all extrinsic and intrinsic tongue muscles. Okay, so now we just want to go over a brief overview of swallowing. There's actually 3 major components, and it comprises of the oral phase, which is the oral prep phase, the oral transit phase, the pharyngeal phase, and then the esophageal phase. The top 2, we really do a lot of analysis. So what do I mean phases of swallowing? You can look at your little picture to the right. And when we talk about oral preparatory phase, we're really looking at how the child is able to suck from the bottle, express the liquid from the bottle. What does that prep look like? How does he procure the food or liquid from utensils? When I give him a spoon, is he able to scrape it off by himself, or is the feeder trying to kind of push it in there and he doesn't have any lip closure? And then chewing. We know a lot of our kids have chewing or mastication problems, and that would be the procurement or trying to form a bolus. When kids don't chew well, obviously they're more inclined to choke. Okay, the next phase, oral transit phase, we know the duration is 1 second or less. The bolus is propelled to the pharynx. When we see this, the soft palate begins to elevate to close off the nasopharynx. The pharyngeal phase, these are kind of the order of events. We have VP closure, which means that the velum closes off, so it makes contact with the posterior pharyngeal wall so that the food doesn't come up the nose. Hyoid movement. If you have hyoid movement, that if you have good elevation, it helps with the swallow. And we look at the elevation and also, yeah, and the anterior movement forward. When we talk about tongue-based,
We go there. We can fill the air.
oh, it's okay. I
Last
think
time we
okay, thank you. It's okay. I thought
Yeah.
someone had a question.
Yeah, go ahead. Yeah. No, Shruti, go
I was
ahead.
like, okay, okay. So if we think about the swallow in the pharyngeal phase of swallowing, we think about velopharyngeal closure, then hyoid movement. It moves up and then forward as we get older. A really important part of the swallow is that tongue base retraction. That tongue base really sets the bolus in motion and helps with the events of swallowing. All too often, we do see that that part is missing, and it really creates some swallowing dysfunction. Laryngeal elevation, we know that the larynx elevates, and the epiglottis is going to tip downward. If we see that the epiglottis doesn't tip downward all the way or it does not invert, we can have difficulty in swallowing. The next is true and false vocal fold closure. We know that the true and false vocal folds close while we're swallowing so that it's the protection of food and liquids from getting or entering the airway. And then initiation of pharyngeal constriction. Very important with our kids with neuromuscular disorders. They may swallow, they may be able to get it to propel to the pharyngeal area, but they don't have that squeezing or that stripping. And when that happens, because of weakness or damage, we have a lot of residue and poor clearance or entrance into the esophagus. And then last but not least, the relaxation or the opening of the cricopharyngus. This allows the food or liquid to enter the esophagus. Oftentimes we may see that there is some opening, it doesn't stay open long enough, or it doesn't stay, the duration or amplitude is reduced. And this is probably due to, if you look at the entire swallow, something in the whole events, the stripping and the pressure point events is contributing to that lack of relaxation and lack of timing. So when we look at swallowing, it's very complex, but it's very exciting to kind of figure out when we do our swallow study and when we do more analysis, where's a problem and how can I fix it? Okay, the esophageal phase is really important, although as a speech pathologist, we only look at the top third. We make sure it gets to the esophagus. Once it gets to the esophagus, then we are, it's really out of our realm, and it's really the radiologist that is going to provide information on strictures or any achalasia. And what happens when you watch the bolus in a swallow study or a modified Barron swallow is we're watching the swallow go from the oral phase to the pharyngeal phase, and then we do a sweep to make sure that that food or liquid that gets into the esophagus enters the stomach. Okay, so that's just basic information, and we'll go from there. I like these pictures. They're kind of nice. It shows you on the left, it says velum closure, hyoid movement, laryngeal elevation, pharyngeal shortening, tongue base retraction, pharyngeal stripping. You think of all that has to really occur for us to swallow. It's amazing that all of us don't have swallowing issues. And if we go to the right, it's a simplistic view, but it's a good schematic because you look at velum closure and pharyngeal stripping wave are primarily important for bolus propulsion, swallowing efficiency. And then if we look at hyoid displacement, why is that so important? Why are we looking at these mechanics? It's because it's very important for airway protection. And then last, but I think the most important, tongue base retraction and pharyngeal shortening. Very important to get that posterior tongue gets the movement starting. Without that pressure to kind of push it down, we're left with a lot of residue and a lot of pharyngeal issues. Okay, so that's just a simplistic view. Of course, it's very complex, and the purpose of this is just kind of give you an overview. Okay, I like this because we think about airway protection. Our bodies are made there. It's amazing how many levels of protection we have to keep that airway from getting liquid or food in them. There's 4 levels, including closure of the true vocal folds, approximation of the false vocal folds, epiglottic inversion, and then the arytenoids to base of the inverted epiglottis. Now, typically the fashion that happens is actually the bottom first. The arytenoids usually come together, and then the epiglottic inversion, approximation. However, depending on what you're eating, what consistency, what your bolus size is, it may change in sequence. But all these are to help reduce aspiration. And still, we have many that do aspirate because of one of these things that are not working properly. Okay, and then this is another beautiful, I like the schematic. It shows the arytenoids, the epiglottis, and the true and false vocal folds. All right, here is, if I can get it, this is a normal swallow. It looks very blurry right here. Okay, first, I just want to say, preface this, wait 1 second. I'll preface this, it may not look very normal at first, but you have to understand we see a lot of complex kids. Once this little guy gets a rhythm, he'll have a good, nice rhythmical sucking pattern. So take a look at this video. That looks nice. Okay, we can stop it. Okay.
Kathy, would you mind showing it in slow motion? Like,
we will, I was going to say, it's really. Okay.
yeah, just to show where is the airway and what is happening to the bolus.
Absolutely. We will, I don't know how to do it in slow motion, but Lauren is going to kind of guide in this.
Just do just break it down.
Can I just talk to you about it? Yeah. Let's see if I toggle it. Okay, let's see if I can do this. Okay, here, right now, here's the nipple, right? Here's the tongue. There's the ear right there, and then there's the airway. So let's go through it, and we'll kind of go through I can toggle it. This will work. So here we go. Let's see. I think it'll work. Okay, if you notice at the beginning of the swallow, the infant, I don't know if you noticed it, but did 2 sucks per swallow. But once he gets his rhythm and he gets a good, we look at the latch. The latch is not great right here, but once he gets a better latch, you'll see a 1-to-1 suck to swallow. That's really important in that it's a nice pattern. You don't want to see the child have like 5 or 6 sucks per swallow. You don't want to see the child work that hard at eating. Eating should be easy, efficient, and safe. So when I look at this video, I'm looking not only at the suck per swallow ratio, but I'm also looking at how rhythmical the pattern is. You'll see that when you see a lot of these kids with premature, that are premature, they don't have that suck, swallow, breathe triad pattern down because they're premature and they didn't develop it. Swallowing develops in utero. So when a term baby comes out, you expect them to have a pretty rhythmical sucking pattern right off the bat. You don't expect them have to learn how to do it. It's more a reflexive type pattern. So let's go through it again. Okay, so structures right here. That is the epiglottis. Here is the vallecula. Here's the piriform sinus. Here is the posterior pharyngeal wall. This right here is the velum, the palate right here. And what you should see is that palate move to touch over here to keep it out of the airway. What you should see is this posterior tongue part move way over here when he swallows to generate that pressure to push it down. And this area here, it's a space, it's called a vallecula. In infants, it's really normal for the liquid or the bolus to cool briefly, or at least touch the vallecula prior to going into the esophagus. This right here is the airway. This is the esophagus. Okay, so now we're going to play it a little bit more. What I like about this is after the swallow, you see clearance here. You don't see any residue in the vallecula. You don't see any residue in the piriform sinus. You don't see any what we call nasopharyngeal reflux up the nose. So everything looks safe. Now I'll play it a little bit faster just to kind of get the idea. And I'll stop. Whoop, I don't know how to Whoops. Okay, and you'll notice there, once he gets a better latch, he starts to do a 1-to-1 suck to swallow. So this is what I mean when I look at a normal swallow. What I don't, oops, sorry. What I don't see, that's okay. What I don't see is that I don't see that there's any residue in there. I don't see penetration or aspiration. And I'm going to do a whole presentation on the swallow study. So this is just one example, because in our third session, we'll talk about the swallow study and fees, and we'll kind of go through that again and with different children and different ages. But this is what normal looks like. I'm going to finish off by doing just this showing again. Now look at it in real time. When you first start analyzing swallow, it is very hard to look at the whole picture. You get so focused on looking at aspiration that you forget to look at the mechanics of the entire swallow. And I think with time, you realize how important it is to do the gestalt or see what the pattern is to try to help these kids. Okay. All right, next we have Lauren, and she's going to talk about practical stuff with breastfeeding and bottle feeding.
So we just wanted to include, because Kathy was talking about kind of normal swallow physiology with infants and things. We just wanted to briefly talk about just as they get older, and we move into the 5 to 6, 7 to 8 as they get older here, talk about some motor patterns you might see. Again, I think next time Natalie and I are going to talk more about just kind of these as they're leaving infancy, getting into toddlerhood. We'll talk more about these things, but I don't think it's a bad thing to hear things more than once. So basically, and again, today we're really focusing on those bottle-fed, breastfed infants. So 3 to 4 months, we're focusing on the bottle and breastfeeding and just swallowing coordination, things like that. When you move to 5 to 6 months, you'll start to see, obviously we'll start to introduce some smooth stage 1 purees, and you'll start to see them opening their mouths more volitionally and just kind of having more active upper lip movement. They're not the best at clearing the bowl of the spoon yet, and they kind of have that little up-down phasic biting pattern. And it's kind of that, we call it like combined with a non-stereotypical vertical chewing pattern, just easy touch up-down motion, kind of like that. 7 to 8 months, they're still doing some stage 1, right? You progress to stage 2, because you'll start to see now with their spoon feeding, the upper lip is working a little bit better, a little more coordinated to really expel that puree from the spoon, and more active tongue lateralization. So you'll start to see that emerging, their tongue kind of moving like this. And then you'll see more simple horizontal shifting, that pattern, horizontal shift with the tongue lateralization, and then more vertical chewing motions will kind of start. And then 9 to 10 months, you'll see stage 2, stage 3. We really don't, I feel like stage 3 a lot, because there are like random chunks throughout the puree. We really like to see a more consistent textured puree. If you're going to have texture, that's good, but you want the whole thing to be consistently textured. So we often will kind of do like more of our mashed foods. It's more of that consistent texture. And you can have some finger feeding starting some of those dissolvable solids. But I think you also have to look at where they are gross motor and developmentally. Are they ready to start some of these mashed foods and these dissolvable solids? Usually we look at crawling as an indicator for that. So yes, age is important, but it's more about that individual child and where they are developmentally that's going to help them progress through the different food textures. And you'll really start to see now both lips actively moving inward to clear the spoon, and they have a lot more just minimal spillage coming out of their mouth, so they're becoming more efficient eaters. And then you'll start to see that vertical chewing motions, but more with the diagonal shift of the jaw. You'll start to see that movement as well. Like you can kind of see the jaw start to move diagonally, and that tongue lateralization starting to look a lot better as well, and just transferring dissolvable solids from side to side, and more bolus shifting really. So I think I'll kind of just stop there. Again, this was just a quick overview, just to go over the normal feeding milestones. We will come back to this in other talks, but just wanted to kind of have this in your kind of just in your brain a little bit there. Okay, so now we'll get to.
Can I, Lauren,
Yeah, go ahead.
can y'all comment on, because we have a lot, our audience is mainly Indian today. You know, there are other modalities used besides bottle feeding in India, primarily, you know, they might use a cup and a bowl and a spoon to feed express milk formula, or they might use it's called a paladi. It's basically like it almost looks like a little lamp that you can pour in. Do we have any data on what that might look like, or if anybody in the audience can chime in on their experience and how that fits in with the bottle feeding? Because I think there are other, even historically, those types of vessels have been used, and we don't really use those here, but I think there are places around the world that do. And so it just be interesting to know how does that fit into the normal infant, you know, the where they are mechanism. Oh, somebody has chimed in here. That's great. Okay, there are studies compare, and can if you can unmute yourself, would you be able to just tell us, or somebody be able to tell us kind of what those studies find with regards to safety and effectiveness and weight gain, and just how good infants are at extracting liquid through those other types of mechanisms? And that's okay if you're not, if no one feels comfortable talking about today. It's just something that we can all think about, I think. And certainly, again, something from the West, I think that we should be paying attention to, that there are multiple ways that this is done around the world. And if they're safe, they should be options. Here we go. Not a significant difference. Okay. So I think in a country like the U.S., where there's so much cultural variability, we're such a, you know, there's so many immigrants here, it might be something that we can think about as well for our kids. Thank you for letting me.
Nikhila?
Yes.
Yeah, there is a message in the chat box. Somebody has said that yes, there are studies comparing the Palade with the Nifty Cup. They have found there is not a significant difference between the two in progression of oral skills and feeding efficiency.
Great. Yeah, if you could share the article, that would be awesome.
She's trying to share the article. Yeah.
Awesome. Thank you so much. I appreciate your input here.
Yeah, I think that's definitely good to consider, because we are mostly, you know, we deal with the bottle feeding, breastfeeding, you know, here, but you're right. There are definitely different modalities for feeding. Okay, so now we'll get more into our clinical swallow evaluations and how we do those evaluations, and really what are the components of a clinical swallow evaluation. So really, as an SLP, we like to start with our clinical swallow evaluation, where we see the child, we assess their feeding and swallowing, and then we kind of go from there to see if we need an instrumental exam like a swallow study or a fees. However, it doesn't always happen that way. I think especially when you are seeing a really high volume of patients, you know, the first time you meet that infant is in radiology, right? And you kind of have to just collect all your information, do the case, you know, case history and all that then and there. You're kind of doing a clinical slash objective study, and you go from there. But a lot of the time too, if that does happen, we'll do our swallow study, and you just kind of explain to caregivers that this is just one assessment, and we'll bring them back for a clinical exam as well. Okay, so when you're doing your clinical evaluation, medical history, this is so important. I think it's just as important as actually watching the infant feed. So, you know, you want to talk about their birth history. Were they premature? Did they have a NICU stay? What happened during their birth history? What was mom's birth history like? You know, and just really getting into that. Also their gastrointestinal history, you know, were they vomiting, significant reflux, any dysmotility issues, things like that. Neurological history too, that's a really big one. Did they have any, you know, an HIE or a hemorrhage, and what grade was that hemorrhage? Respiratory, airway history. So did they have to be intubated? Did they require supplemental oxygen? And then airway history, laryngomalacia, you know, all those things. And of course, we're always thinking, how would this impact their swallowing? You know, their cardiac history, that's a huge one as well. You know, just and understanding if they have that cardiac history, again, how will that impact their feeding and swallowing? Surgical history as well. We see a lot of kids with cardiac procedures, and depending on what was done, what type of cardiac surgery they had, was the recurrent laryngeal nerve could be affected, which impacts vocal fold mobility. So you want to know all of that. And then developmental history. So how are they progressing with their developmental milestones? Because that's really important too. Head control, trunk control, their tone. And just also when you're going to go in advance for those purees and other things, you want to kind of know where they're at with that. And also, I think sometimes we screen for that. And if I have more questions or concern, I send them to physical therapy because if the child needs that type of support, we need to make sure we get them into that because that's only, again, going to support their feeding and swallowing. So really looking at all of these things. And I think if you have a good picture of their history, you can start to make some hypotheses, in your head about, okay, this child might struggle with this during feeding because they have this cardiac history and also their strengths too. You really want to not always just look at what are they going to struggle with, but also their strengths and look at the whole picture of the child before you go in, and really assess their feeding. Okay, so then, you go through your medical history, do that. And so then you'll start to take a look at their past feeding history and current feeding regimen. So past and present are both very important. So if they were in the NICU, what were they doing, right? Were they doing more non-nutritive? Were they doing pacifier dips or detached nipple, things like that? Are they totally PO feeding? Do they have a G tube or NG tube? Or are they utilizing a dual feeding system? So that would really mean, they're taking some of their feeds through the NG tube or G tube and then also doing oral feeds. So, and we have a lot of kids, I feel like, who are on dual feeding systems just personally. So they're getting some of that practice, right? And then also though, they still have their supplemental system. You want to see who is feeding this child, right? Family members, caregivers, and kind of what we were talking about before, just culturally too. And, what are their customs, traditions, those types of things. And we have, some babies who are fed by one person all day. I've had some babies that are fed by 4 people or 5 people, if you have more of the whole family taking care of that baby. So it's really important to know who's feeding and kind of what is their knowledge with feeding and swallowing and what that baby needs. You want to look at if they're on formula or express breast milk, are they breastfeeding? Formula type is really important because that can give you, are they on a hydrolyzed formula? Are they on an elemental formula? That kind of gives you a, did someone put something in the chat? A look into their gastrointestinal history too as well. You want to look at the bottle type, the flow rate. And I think if they are using a bottle, right? Or if they're feeding some other way. There are just so many types of bottles now and flow rates are not consistent from brand to brand. And just looking at that. And then you want to look at, how much are they taking for each feeding and how long is it taking them to complete that volume? Really looking at just their efficiency. And then we want to monitor for signs of, these are just clinical signs of aspiration, right? So we'll get into what those signs are more on some other slides. But just as important as all of these other things I was listing are their stress cues too. And parents sometimes don't know what to look for stress cues wise, but they're really good at telling you, yeah, my baby just looks stressed when they're eating or they're pulling away. Like they don't have to know exactly what to look for, but they know when their child is struggling or feeling stressed. And I think they're really the best people who know that. They know their babies the best. And then feeding positioning, right? How are they feeding this baby? Are they on their back? Are they more upright? Are they doing a sideline? Just looking at all of these things and getting a good clinical picture of how this child or baby is feeding. Any questions on that? Kind of went through a lot.
Quick question to the
Sure.
Indian SLPs. It seems like we have a lot of different bottles. What are the typical bottles you have there? Is it standard or there are multiple bottles in India as well? And
Yeah,
also same thing with the nipple size. Do you have all the different nipple size or people modify things as they go along? What's
Yeah,
your experience been
right.
in India?
I feel like here we use the Dr. Brown's system the most. We do have, like, we'll use MAM sometimes in things for our babies who kind of have more of a compression pattern. I think it kind of depends too on what the baby's doing, what patterns they're showing you to pick which bottle is going to be best for them. But here I'll tell you, in the NICU too, like it's Dr. Brown's. That's what we're usually starting with. Do you have anything?
So I was asking the Indian crowd what they use. Is there?
Oh, sorry. That's okay. Yeah.
Yeah, there's like, we have a deluge of different bottles in this country. I was just making sure what they have there and what they typically use.
Yeah, that's good.
Yeah.
Good question.
Mhm.
Anyone wants to take that? Come on, guys.
Sure. So this is Alessia Yarambala. I am a
Hmm?
pediatric discharge therapist from an NRC run by UNICEF. So the
Mhm.
general practice that we do is not recommend bottles here, considering the hygiene and how they sterilize it. We
Mhm.
rather shift them to a spoon, a wati spoon, which is most comfortable and the parents can take back, or a
Mhm.
palade or a lifted cup. Uh, as regards to bottles, there we haven't really been using any standardized per se, but yes, the
Mhm.
flow rate differs based on the child's condition. So in cases like left lip and palate, we have the elongated nipple one, which they can receive dry pad. We generally do a baby swallow to check of how well is the airway safety maintained with the bottle, as opposed to using a Paladin or a Vati spoon. So we do a comparative study before we really recommend something when a child is
Mhm.
being discharged from the work.
Do you have the different nipple sizes like we have here, extra preemie, 1, 2, 3, 4, to control the flow rate? Do you have the different sizes of nipple, or it comes in a standard size?
So there are available, but I'm not sure because we don't use bottles in general in the
Okay.
ward.
There are
So
different sizes like 0 month, 3 month, 6 month. It is based on months.
Okay.
There are some brands that come up and say like you can use this for 0+ month and 3+ month,
Mhm.
and it's basically the teat difference and the
Mhm.
size of the hole varies.
So do you use that sometimes in a 6-month-old? You might use a 0-month nipple to just slow down the flow rate.
Yes, sometimes it is recommended that way because
Okay.
of the size of the hole.
Okay. Thank you.
But is there a certain bottle, like we have Dr. Brown's here because of those nipple, like it goes really in incremental periods, like ultra preemie, transition, 1, 2. Do you have a certain bottle? I know you said you have some. Is there a brand that we could look up or?
Tommy Toppy.
Tommy Tippy.
Yeah, people have mentioned Tommy Tippy. Maybe Tommy Toppy is what it says here. Dr. Brown's, Medela.
Okay. But that's the
Some-
same, yeah.
that we
Okay, perfect.
Cool.
This is great
It's
information
interesting.
because
Yeah.
it's so fun to hear what you guys are doing and how we can maybe modify things that we're doing here to for cultural differences and different feeding
Yeah.
practices. It's awesome. So, okay. Any other questions or?
Okay. So we went through, we did the medical history, we did the feeding history, all that type of stuff. And so then I'll move more into, we look at the infant oral reflexes, so tongue protrusion, tongue lateralization, phasic bite, gag, cough. And really these are all protective, right, initially. And so for tongue protrusion, I'll just kind of like place my finger, really if you just put it kind of close to their lip or the tongue tip, you'll see that their tongue protrude out. And that'll diminish around that 4 to 6 months right there. And then tongue lateralization, that's integrated around the 6 to 9 months. And that's pretty easy, I feel like, to elicit too. You just kind of can swipe, like I'll just kind of swipe the side of their tongue, or even when I just put my finger there, you'll start to see that tongue move that way. And then phasic bite, just pressing down like on the side on their lower gum, applying a little bit of pressure, you'll start to see some of that phasic bite. And then the gag, yeah, so the gag is very anterior on the tongue initially because it is protective, right? And then as they have more experiences, they get older, that reflex moves back. And like we all have a gag reflex still, it's just further back, right? Because it's just not as protective anymore. And then we have cough, obviously, too. So just a quick overview of those, but we do look at those during our clinical swallow evaluation. I don't always like to elicit the gag, but someone does. Either the ENT, someone always does, so you'll see it. So we get that done. And then this is just also, so I actually just kind of screenshot. I wonder why there's this red.
I don't know,
coming up.
there's
I don't
two.
know
Do you
why
see
the
red on
red
your
is coming
screen?
up. Sorry. I don't know why that's happening. But just ignore that. But I just screenshot this from our actual documentation so you could see it. Side note too, I'm wondering if we could send our templates, like some of our documentation, if people want those to kind of start building their documentation a little more, maybe we could send those as well. So you guys
Collaborate.
and exactly change things, whatever we want to do. But this again is kind of looking more at the non-nutritive oral motor reflexes. So I'll either do this with just the glove finger or the pacifier, kind of depends on the child. Some days, they're so hungry, they don't want that pacifier in their mouth. They're like, give me the bottle, or, it just kind of depends on the child. But you look at their latch, you'll look at, so if I'm using my glove finger, I'll kind of look at their latch, how quickly was it that they were able to do that, look at the sucking burst length. So how many sucks are they doing? They're pretty strong, their tongue cupping, you can actually feel that when you do the glove finger pretty well. You can feel that their suck strength, their respiratory regulation. So how are they doing are they having to stop and take those really long, respiratory pauses before they do another sucking burst, things like that. Rooting reflex could have kind of been at the top of that list even before any of these. Again, gags there. Secretion management, just so it's developmentally appropriate, right? Just looking at their oral secretion management. Looking at their vocal quality and volume. Sometimes that's hard if the infants aren't, they're kind of quiet, but usually if they cry, I feel like, and they will at some point, you'll be able to get that information. Feeding readiness cues, right? Are they kind of signaling they're ready, starting to move, hands to mouth, maybe they're smacking their lips, things like that. Pre-feeding intervention. So we'll do like the pacifier. Do you do pacifier dips with some of our little friends? Positioning, right? Swaddling them, things like that. And then oral mechanism, obviously looking at their soft palate, looking at their range of motion of their tongue, just really looking inside the mouth as well. And I feel like we kind of do that one, like in our multidisciplinary clinic when we're with the otolaryngologist, we're all kind of looking in their mouths and looking at all that. So it's nice to have two people looking at these things. And we already went through those infant reflexes, but I just included them again. So on our documentation, we just have kind of like drop downs. So it makes it a little bit faster built in, like for all of these things. I don't know what other people do or,
Our institutions.
institutions do, but this could just be something to add or change or whatever you'd want to do. I just wanted to show you what we kind of do. I don't know if anyone has anything to add either. If they find something that's quicker or more efficient, can always let us know too. Okay, and then, so that was kind of our non-nutritive assessment. Then, well, this is going to, as we're learning today, look different for depending on where you are, right? So this might not be totally applicable all the time. But for us, we're really looking at, so we'll do bottle feeding and breast because that's what we're doing. But so we look at the oral phase and the pharyngeal phase. Pharyngeal as best as we can. Clinicals, you really can't get the full analysis of that pharyngeal phase, but we'll get into that. So again, oral phase, we're looking at the bottle, the nipple flow rate like we talked about, that rooting, the latch to the nipple. Is it a pretty prompt latch? Is the latch shallow? Are their lips properly flanged? Those types of things. Looking at the labial seal actually on the nipple. So with the lips on the nipple, is there a loose approximation of the lips? Are they frequently delatching on and off? Things like that. Suck swallow ratio. So you really want a 1-to-1 or 1 to 3 to 1 for that suck swallow, or suck swallow, or suck swallow, suck swallow, kind of like that, just in that 1 to 3 range, 1 to 3 sucks per swallow. Sucking burst. So you want to look at, okay, does this child have pretty long sucking bursts initially? 10 plus, 15 plus? And then do they go to like 2 sucking bursts, or are they pretty, arrhythmical? You're looking at those sucking burst lengths. And rhythmicity kind of ties in with that. You want it to be a nice rhythmical pattern. And actually in Kathy's swallow study, initially, that one we watched, initially, if you looked at the rhythmicity, it was kind of like not very rhythmical, and you can see it. It looks kind of choppy, but then that baby really got into that nice rhythmical pattern. And that's okay. Babies are still learning, and I don't know that baby's history. But I find that suck swallow ratio and things like that take some time to practice to be able to count and really see that just clinically. I think that can be hard at first. And then the coordination of their suck swallow breathe. So suck swallow breathe triad, right? Are they doing suck swallow breathe, and you can hear that kind of exhale, or are they doing suck swallow breathe, they're stopping, you see that increased work of breathing, they're having to take frequent ventilation pauses because they're actually not integrating that breathing well into the triad. So really looking at that and looking at that coordination of that suck swallow breathe triad. And then pharyngeal phase. So again, clinically, you can't really, there are signs we look for, but if you really want to look at the swallow physiology and look at this pharyngeal phase in depth, you need an instrumental exam. So things we will look for, though, is the more obvious ones, right? That coughing, choking, increased pharyngeal congestion, wet vocal quality. So when they cry, sometimes you'll hear that kind of gurgliness, and you can feel that kind of almost chest congestion, like if you put your hand on their back and really kind of feel for that. And sometimes you'll hear that like that gulping, and then that chest congestion as well. And then obviously increased work of breathing, that type of thing. So these are things we're looking for. But it's hard. Pharyngally, I think it's hard to assess just by a feeding observation. But you can still get good information, I would say. Again, this might not apply totally to what you're all doing. So now I'm kind of feeling like,
you
this
talk about
doesn't-
breastfeeding.
yeah, I know this doesn't totally apply. But I still feel like the signs do, the pharyngeal clinical signs and things, I think are applicable.
Absolutely.
Yeah,
And the clinical gives you information of what they're doing at home anyway.
exactly.
So if they're doing that at home and you see some signs, it's really to get a picture of what's happening.
Yeah.
And then when you see signs of pharyngeal involvement, then you say, I need a fees or I need a swallow study, depending on the child's age and what they're drinking or eating.
So this is the table we use if we're doing more of our bottle feeding assessment. We always look at their state before we start, during, and post. Very important, the infant state. Are they quiet alert? Were they sleeping? Did they transition to a deep sleep after? Things like that. And again, we have our drop downs that we just kind of go through. So I won't go through all of this because I feel like I just kind of did this, and I'm just looking at time too. So again, listening to consistency, that's important though, because some of our infants come in with thickened liquids sometimes. So we need to look at that. We went through the root, gape response, latch, all these things. Again, this is just to give you an idea of what's on our documentation. I do want to point out though, so we stress cues. I like that we include the motoric stress cues, so finger splaying, hard eye blinks, eyebrow furrowing, those motoric cues, and then the disengagement, so actually pulling off of the nipple or tongue thrusting to get the nipple or whatever you're using out of their mouth, showing you, I don't want to do this anymore, I am disengaging. A lot of our infants too, I'll see a lot, they transition to more of a non-nutritive pattern. They're not really nutritively feeding. They're just kind of, I'm going to sit here and, just, I don't really want to engage in this feeding anymore. And I'm not really expelling anything from the nipple anymore. And then at the bottom too, I think it's cut off on my screen here a little bit, but just looking at overall feeding efficiency, right? How much did they take and how long and things like that. So again, this is just to give you an idea of what our documentation is looking like.
And then really look at the bottles that they're using, because
Sorry, I think it's a really good point that you brought up about disengagement. Because if we're using other modalities that are more passive in nature, like if it's we're like the Paladay is a little bit more of pouring as opposed to always sucking and initiating. If they're not if they're not interested or not active, that put them at risk for aspiration. So I think that's a great point of the cues being important.
Yes, I think those the infant cues and we talk about infant-led feeding, you're exactly right. I think it's just as important as the mechanics, right? Or the oral and pharyngeal phase and all those things. So yeah, that's a very good point. Okay.
And I think really with the whole dynamic of this is that just with some simple changes, you can change the entire feeding without even doing an
Okay.
instrumental exam. They're going to talk about that. And also when you're looking at, for us, the bottles, sometimes they'll come in and they say, I'm using a bottle level 2 and it's thickened feeds, meaning it could be slightly thick or mildly thick. And then I'll look at the bottle and I can see that they've cut it. So make sure that you kind of, they're showing you the right bottle, because sometimes they are saying a number, but if you've altered the bottle in any way because of the child's performance, then that affects the flow rate.
So you did your evaluation. So now what are you going to recommend and what is your intervention? So especially with the infants, we have a few things we can do, right? The positional changes, put them more on side lying, swaddle them. I like to do elevated side lying. I think that works really well for a lot of my infants. Your flow rate change. Again, maybe you're just after assessing them or the bottle type they're using or things like that. Do they need a slower flow rate? And really, educating the caregivers and the feeders on how important it is to stay consistent with these recommendations. So not constantly changing the bottle or changing your feeding modality, like giving this baby a chance to learn and develop their skills. And we can always change things, right? We can, I'm not saying you can't, but don't constantly be changing things, right? If we recommend this, let's try it, let's see how it goes. And then you can come back to the drawing table if needed. And then working on those safe swallow compensatory strategies. So pacing. So does this baby need more strict external pacing, right? And a lot of those babies who have poor respiratory regulation or our cardiac babies, things like that. Do you need to be like consistently pacing them and tilting that bottle down and draining the nipple so that that baby can take ventilation pauses and breathe and get more coordinated with that suck, swallow, breathe triad? Can you do more cue-based co-regulated pacing where and we're always following that infant's lead, right? But you are kind of working with them. And when they stop, okay, I'm going to tilt the bottle. They're telling me, hey, I need a second here to breathe. And then or you remove the bottle or whatever feeding modality, you're using. And then, do we need something more objective, like a fees or a swallow study? And I put and liquid thickening with this because I think we like our objective studies before we recommend some sort of thick and liquid. I will say though, that I think it's a case by case basis too. Sometimes we'll do thick and liquids naturally, knowing it's just for the short term, right? Like if we have a baby with laryngomalacia or something, I've done that before where we will thicken, but again, it's for the short term and just to see if it helps this baby be a safer, more efficient feeder. But really, I think for liquid thickening, you want more of an objective study. Do you agree with that?
Yes.
Yeah,
Absolutely.
I agree. I think, but again, I think it is
Because
you have to
sometimes
look at the
thickening,
isn't always better.
Right.
We know that too.
Right.
Especially if they have pharyngeal phase deficits, they have poor pharyngeal constriction, they can have that residue. Thicker can actually make that worse. So I would say, yes, get your objective swallow or instrumental before you make that recommendation. So when they're an infant, yeah, you have some things you can do, right? I think a lot of it too, and it is also just really making sure caregivers understand these recommendations, why we are doing this, and how it's going to help their baby feed safely and more efficiently. Anything else? Any questions with that? Okay. So, and then goals. I just put some long-term goals on here just to basically give some examples of how we will write these goals and like if we need to see this infant back for more therapy after we do our clinical evaluation. So for me, and this will change from SLP to SLP, but I organize it in my brain as skill, safety, and then caregiver education, because these are the real main points, or main categories, I will say, when writing my goals. So again, these are more long-term. These are not the more measurable ones. But so my first one would be you're improving their oral mode of feeding skills and swallow coordination because you want them to consume the least restrictive liquid viscosity via whatever feeding modality you have safely and efficiently to support their growth and neurodevelopment, right? You could have a overall, stability or stress cue goal as well. Then my next one, this is the safety, right? How are they gonna feed? How are they gonna do this safely without demonstrating clinical signs or just pulmonary decline? Because we're always gonna be looking at their pulmonary health and, you know, that domain as well. And then caregivers implementing those safe swallow strategies during feedings independently to promote those positive and safe oral feeding experiences. I sometimes too will have long-term goals that, like, again, let's say an infant's on a thicker liquid or something, and we'll do therapy and then they're ready to repeat that instrumental, either that fees or that swallow study. So I'll write a goal saying, you know, they will participate in a repeat instrumental evaluation specifically to assess thin liquid. So just what are the big picture things you want to do with this infant? And then of course, like your more short-term goals will be more measurable. So let's say, and again, this might not, some of my examples are just not applicable and I'm realizing this, but if you are doing the bottle, like, and you're working on latch, like baby will demonstrate an adequate latch with proper lip flanging on 85% of opportunities over 2 therapy sessions. Very measurable, specific goals. And I always write my short-term goals, kind of like thinking about the things we're evaluating on a swallow study for my more motor skills and swallow coordination, or they'll improve coordination of the suck, swallow, breathe triad, you know, by completing 8+ sucking bursts 5 times during a feeding, like if they have really short sucking bursts, and you know, just things like that. Again, very specific, measurable goals. But I also don't know how how therapy works and insurance and that type of stuff. So I don't, that would be a very interesting conversation to have at some point too. But for us, a lot of this is for insurance purposes.
Yes.
And you have to consider that too when you're making these plans.
Measurable goals.
Yes, exactly. So again, your domain: skill, safety, caregiver education. Caregiver education, I personally think, is top of my list when I'm in these sessions, because they are with that baby the most and they've got to feel comfortable with understanding the plan, how we're going to execute the plan, and what are our strategies for the plan. So to me, I'd spend a lot of my time doing that in my sessions as well. Okay. Sorry, we're kind of, okay. I'm gonna roll through breastfeeding here quickly. And I just wanted to, and if anyone has any other positions they like to use too as well, I'm just gonna quickly go through positioning because I think that's, you know, where we start with breastfeeding. You have your cradle posture. So basically baby is on mom's forearm, the same side as the breast there. So like right forearm to right breast. You can see that picture there. All of these pictures were taken. If there's one little pocket guide or something you would get for breastfeeding, I love this resource. It's the Pocket Guide for Lactation Management. It's really good. All these pictures are in there. I'm just going to go kind of quickly through these. Cross cradle. So it would be, they're on the arm, like the right arm, and they're being supported, but they're on the left breast, right? They're crossing mother's chest. And you're always supporting the back of the neck, or kind of their back more, not their head, because you want their head to be able to move more freely when you are breastfeeding. Again, I'm kind of just rolling through these quickly. You can do the football or clutch posture, and they're kind of like on their back side a little bit, and their legs and feet are kind of wrapped around the past the mom's side right there. And you can see baby, it's kind of like, well, I guess American football. That'd be like an American football. That's what that looks like there. Again, these are just pictures you can see. I like this one, the semi-reclined. So mom is reclined and baby is kind of, yeah, mom's leaning back, exactly. And the baby lies her body in kind of a more prone position. I like this one really for when mom has a heavier letdown and baby needs to control that flow a little bit more. This is one we'll try. This is kind of hard to do in the clinic if you can't, you know, depending on what chairs you have and things like that. I also like this one a lot, side lying, and we also mimic this one, bottle feeding essentially as well, that side lying position. Mom lays on her side, baby's on the side. They're supported by like a towel or blanket kind of on the back. And they just kind of feed on their side like that. I like this too when mom is a heavier letdown, or just baby can kind of control the flow rate generally a little bit better. I do like that one. And then you have Australian with mom just totally laying down, or mom can even be in a chair. I guess that would be more semi-reclined, but baby more is on top, like this. And again, this is a nice one too when mom is a heavy letdown. I just wanted to give you some just basic positioning things. So we'll start there a lot with moms too, just looking at that. Okay, quickly, typical breastfeeding. Obviously, you're going to look at their cues and if they're ready. Now, I will say, obviously, when you're doing a clinical or you're in clinic, sometimes you miss these cues. The baby's already crying. We know crying is a later cue of feeding. You do the best you can with that. You put them in whichever position is optimal for them. Again, not having your hand, that's one thing I always look for. How is the mother or caregiver, where is their hand? Is it on their back? And then you want to make sure you're moving baby to the breast, not putting the breast in baby's mouth. And with that being said too, like contorting the breast or squeezing it or anything like that, because that can really affect how that baby is going to latch, things like that. I always say my best thing too is to look for, you want to see if that baby is, their nose is to mom's nipple, because what that's going to do is they're going to have to tilt their head back and get a nice wide gape. And you want to see that wide gape and then kind of go up and over onto the breast. You want that motion versus the baby just going right on to the center of the breast, because you want an asymmetrical latch as well. You want the chin, lower lip, tongue to meet the breast first. And so again, they're kind of going up and over, and you'll see the top part of the areola, because that's the asymmetrical latch. And that is what you want. You want more of the bottom part in the mouth there. And then you'll just see suckling begin. So you'll see more of that up-down pattern. That's fine. As they move though, you want to see more of the rocking pattern of the jaw, or that piston motion. Sometimes you'll hear that. And you want to kind of see it like right here, like their ear, it kind of moves right there a little bit. So you see that rocking motion more. And then, yeah, that's kind of the things I'm looking for. It all happens very quickly, I feel like. So just some typical breastfeeding there. This is our breastfeeding assessment. Again, this is what we use. Oh, I think it's okay. Again, looking at their positioning, looking at that. One thing I want to point out, the gape response is a really good one. And then looking at their latch and looking at the angle of their latch. You want about 140 degrees. So if you look at from the lower lip to the upper lip, 140, obviously you don't have to measure that, something like that. It's just a guide, right? Because I think a lot of nipple pain comes from those shallow latches or just incorrect positioning, things like that. And the angle of the latch is really important. So just looking at that. And we already went through a lot of this. Again, there's stress cues, all those types of things. So I think for me with breastfeeding, positioning is the biggest thing. Their gape, their latch, angle of that latch, that type of thing. Again, so.
We have a question in the chat about what are your thoughts on the NEO-EAT questionnaires?
Yeah. We don't typically use those. Do you use those at all? I don't.
No.
Yeah. Because they're more of a questionnaire, exactly. And but I don't think those are bad to use. I think you can definitely use those. We just I think we kind of developed our own questions that we ask, and kind of similar. But yeah, I think that's a fine resource to use. Yep. Okay.
Yeah, all right, yeah.
All right. We're almost done here. Yeah, you can do this one.
Okay, so I thank you for your attention. This has been a good didactic kind of conversation. We know that we love the bedside swallow. It gives us a lot of clinical information, sometimes with just really positional changes, modifying the liquid flow rate is all that baby needs. And just pairing them with the right setup would be all they need. But the limitations are pretty big. They can only give you some oral phased abilities. It really can't look at the palate. It can't see through what it doesn't know. You can surmise by nasopharyngeal regurgitation, but to really see it, you need an instrumental exam. It does not give you information on pharyngeal swallow physiology, but it can give you some signs. You can suspect it. Like when we just know that child needs to clear his throat, something's in there. So there's something in there that I know he's got, he's at risk for aspirating. We look at their pulmonary health. We look at their, all their qualifiers that lead us to believe, hey, this kid needs some more help. So we'll do instrumental. But a good clinical bedside evaluation gives us valuable information that can really shorten the swallow study itself. If I do a really good clinical and I have to take that child to do a swallow study, I know exactly my plan of action. I want to reduce radiation time. I want to problem solve. So you're more ready for the evaluation. And I think basically that's it. We know these are just fundamentals of, this is an old study, but I love Joan Arvidson. She's the queen of pediatric swallowing, and she's my idol, so I love her. So anytime I can reference her information, I do. But it was just a typical retrospective study looking at neurologically impaired kids. They noticed that of the kids that aspirate, 94 are silent aspirating. So it's huge. So our neurologically impaired kids, they might not aspirate, though those that do are silent. They're not going to give you that cough. So that's why a swallow study is necessary. And then last but not least, silent aspiration, who's at risk? Look at the bottom, there's a lot. Laryngeal cleft. So if you look at the unilateral vocal fold paralysis, laryngeal cleft, laryngomalacia, developmental delay, seizure, syndrome, congenital heart diseases were all associated with silent aspiration. So many of our preemies, many of our neurologic, many of our genetic kids have silent aspiration. So they may go on to do an instrumental exam. Okay, and we can.
Yeah. And then lastly here, just
yes.
resources. So today was just an hour talk, you know, it's pretty just like an overview of things, but these are some courses that I found very helpful and some just books and also textbooks. So I have to say I absolutely love this first one on the left side here, pediatric feeding disorders, the pink one. This is so great if you're just looking for its infant through toddlers and its treatment and assessment, just more for the speech pathologist. And then pediatric dysphagia in the bottom right corner. This is by two of our physicians that work here, actually. This is really great from the aerodigestive perspective, multidisciplinary care. They're just different options for you. I know there's a lot to learn, and I feel like things change. We know that based on our research and new research that comes out. So, but these are just some courses to get you started too that I have found very, very helpful. So, do you want to screenshot that or something? You can do that too. But just some things to get you started as well, or continue your education. You know?
Absolutely.
So, okay. I think that's it.
Anyone has any questions?
Thank you so much, Lauren and Kathy. The wonderful way to start the program. You started with basics, and you have later with a normal situation and abnormal situation. So thank you so much for that. So now I have a few questions as a clinician. I see, mothers coming off late with, a lot of mothers complaining that I don't have enough milk to feed my child. So that is the, very, very common situation we are facing now, rather than some 5 years or 10 years back. So what is the reason for that? Number one. Number two, if that is the situation, when do you suggest to shift from breastfeeding to bottle feed? Is there any criteria for that? When is the time you suggest to shift from this to, because there are a lot of problems nowadays, because anybody comes and says that I don't have enough milk. Okay, start bottle feed. So this is the scenario what we are facing now. Is there any strict criteria for that? Because of the bottle feeding, as clinician, I see a lot of other problems like OMEs and other stuff, recurrent infections and all those things. So I want some clarity for that. Number one. Number two, the frequency of feeding.
do you wait for cues all the time, or you suggest some, time period? So like, 2 hours or 3 hours, something like that. Don't have to wait for the cues. You start feeding the child. Is that something you can suggest for these two questions? Thank you so much.
Okay, well, we love cue-based feeding.
Yeah.
I mean, basically our NICU, we've evolved. It used to be you feed the baby every so often, and now we look for their cues, their hunger cues. Having said that, sometimes it doesn't work that way, but that is our goal. So cue-based feeding is huge, and we really try to follow that. How long should someone breastfeed? That is certainly personal. And I
think this is a hard question to answer because it's so case by case.
Yeah.
And really what's going on with that baby and the mother. So you're right. It's a dyad. It's not just dependent on baby, it's mother and baby. So I get what you're saying with like milk supply or mother's nipple shape. Like there are other reasons why breastfeeding cannot be going well, like you're saying, and it's not just baby. I feel like we just want that baby to gain weight and have positive feeding experiences. So a lot of the time, like I will never say stop breastfeeding, but I will introduce the bottle at that point. I don't know what you do.
Yeah,
Do you
I
do
mean,
that?
you can't, you take what information you have. There's ways that lactation consultants have helped us to stimulate milk production.
Yes.
So there's ways that they can help us. But if that child truly isn't gaining weight, it sometimes isn't even the breast, it may be the baby. Like, that's
a
what I find.
dyad.
It's a dyad. And we see that it's not all, this mother has tried 1,000,000 bottles. She'll bring in 100 bottles, and it's the child that cannot latch, that has difficulty with other reasons, that we try to pair what device, what vessel works for them. And it may not be a bottle. We don't even like bottles many times.
Yeah.
Because they don't do well.
Right.
So,
But then sometimes milk supply, it's not good because of how exactly how that baby's feeding. They're not expressing the milk they should from the breast. So then, the mother doesn't make more milk. So
tough question.
It's a tough question. And we don't really have to be clear, like a protocol of like when you introduce and things, I think it is just so dependent on that baby and that mom. Right?
Even with breastfeeding, like we don't say stop breastfeeding ever.
Yeah.
That's really not my role. I think there's so much more to it. But I do say at 6 months, you need to try other foods to get, because we found that sometimes if you wait too long, you miss a critical window, right? So yes, you can breastfeed, but let's add this and add skill building.
Yeah. That's a really good question.
I know, you have good questions.
Because with milk supply, and do you have is lactation like a part of your team? Like, do you have lactation and things or?
Yeah. We do have in our hospital, we do have lactational specialists, but unfortunately, not many centers have separate lactational specialists. And most of the time in India, it is the pediatricians who take the call, right? So like then it is a little difficult for them to cut a line, like from here onwards. This is not going to work. So we have to start the bottle or the some other modalities. So they can't spend much time, spending with the parents and the caregivers and the child. They can't see those nuances what you people are talking about. So this is the biggest problem now. So easiest way is to start with bottles. Then the problem of other things will start.
Right. That's tough. That's very tough. Because with milk supply and things too, I just send them directly. I will get lactation involved, or I'm like, okay, we need to figure this out and just give them a really good evaluation.
So is it really the milk supply or is the child?
Sometimes it's both.
It's
like sometimes to me that's hard to tease out what it is. Sometimes even too.
Excuse me, sir. Can I add?
Yeah, please.
Yeah, sir, I'm Dr. Deepthi KJ here. I'm a neonatologist, neonatal specialist, feeding specialist, working over here. I'm a speech and language pathologist also. So, based on my experience, sir, I'm also a lactation professional. So, what I have seen is that most of the babies or the mothers who come with these issues are the mothers who have had babies with high risk, that is the babies are in NICU because of various issues and all those things. And most of these mothers, they don't receive the lactation support at all. They have not been told that you have to express breast milk, you have to maintain breast milk, how important it is. And we all know that between 0 to 15 days post birth, the milk supply establishment is hormonal based, and gradually because the baby starts sucking more at the breast, it gradually turns into CNS control based. But that critical window, they don't get any support whatsoever, and they end up having no milk supply. And that is one of the reasons why I have seen that mothers keep saying that I don't have milk in me. So, and on top of it, the C-section, which is done, the blood pressure, the gestational diabetes, or the hormonal issues, which most of the mothers are currently facing, that also impacts the milk supply. And nowhere have they been educated that, okay, these are all the things which are impacting your initial milk establishment. So you have to express milk consistently, and then your milk establishment will happen. But that is never done, sir.
That's
So,
interesting.
and as you, yes, as you rightly said, it takes a lot of manpower and lot of time. And with our hospital having at least 300 babies in a month, so the manpower is quite difficult. So it becomes difficult. Yes.
Yeah, and that's just so different from here in that like all of our all their lactation is in there so quick here. So I think that's you're right. That's a totally different management just style and just what's available, right? So that's really
Yes.
interesting to hear.
And language is also a big issue. Like I work in a hospital where there are multilingualism, like almost 5 to 6 languages are very often spoken, and I speak only 2 to 3 languages. So we need a interpreter. Yeah,
love
so all those are a big issue actually.
That is a that is a different discussion altogether, because there's a national discussion.
Yes.
So let's not get into that now.
Yes, sir. And also, I just wanted to add on, sir, regarding the bottle, which was brought up in the initial part. One of the main reasons why we don't have bottles being dispensed at the hospital is because of the Indian Milk Substitution Act. So, according to that, formula selling and the bottle selling in the hospital is quite restricted. So, that is one reason. And again, the over the counter, most of the time we get anticolic feeding bottles or narrow neck feeding bottles or broad neck feeding bottles. And yes, the whole of the milk delivery, the volume is determined by either it is XS, S, small, medium, large. That's it. The primary baby, extra primary baby bottle, nipple, all those things are not readily available. Even for that matter, the Medela bottle or the Brown's bottle and all is not easily available in the market. Most of the parents who come to me, and if they have bought it, they have bought it through either Amazon or any other online platforms, sir. So that's one thing which is the problem. And definitely there's no regulation as such, like how in the West you have a regulated size and the flow which is there, that is not there in India.
Right. Wow.
And we have this whole like
I just keep
publication
saying wow because
on,
my mind
we have a
is
whole
blown
publication
away,
on
but-
every nipple and what the flow
Yeah.
rate is. It's almost it's overwhelming. Yes.
So you have a lot of hurdles.
A lot
that
of
you are
hurdles.
Trying to work around.
So, Dr. Deepthi, next time, I think you need to add in, as we are discussing, if you're doing any measures to, like our team is talking about different strategies, if you guys are doing something for the people who don't have all the resources, it might be a good one for you to add from Indian context, what you do differently and stuff, so that it becomes more practical for rest of the people as well. So just make sure to chime in anyone from that group, if you guys are doing anything differently, or if you have a special way of doing it, because ultimately it needs to reach out to all the different specialists in the Indian context, how they go about it. So just make sure everyone chimes in their experiences and how they go about it as well.
Yes, agreed.
This has been
Yeah.
really good.
Yes.
Thank you all. Thank you, Kathy and Lauren. Appreciate you joining in, and thank you all for coming in. See you next month.
We'll be back.
Yeah,
Bye.
sure. Thank you. Thank you so much.
Right.
Thanks, Deepak. Thanks, Nikhila and Kathy Lauren
Thank you. Sure.
for the wonderful start. So we'll meet
Good.
next month.
Okay,
Thank you, sir.
bye.
Yeah.
Thank you.
Bye-bye. Thank you.
Thank you.
Thank you. It was a wonderful session.